Hi, so thanks for joining us here in Geneva, in sunny Geneva. I'm David Sinclair, the Chief Executive of the International Longevity Centre in the UK. We're here under the guise today of the Immunisation for All Ages Coalition, which is focused on and advocates for the understanding of life course immunisation in a real world context. And the coalition came together about 5 or 6 years ago. As members, we have Jane from the International Federation on Aging. We have Martha from UN Shot at Life. We have Lois from FIP. We have Dr. Lamazi from the World Federation of Public Health. And we have the International Longevity Centre, who's ourselves. And my colleague Esther will say a few words later on. Clearly, we are, as you'll all be aware, we're living longer. And over the last sort of 60 or 70, 100 years, really, we've massively succeeded in reducing mortality amongst younger people, fundamentally through things like vaccination and clean water. Over the last sort of 30 or 40 years, we've been doing that in adults as well. And again, vaccination started to play a really important role in relation to that. COVID has, of course, highlighted the the opportunities and indeed the challenges that come around around adult vaccines across the world. And now that the WHO has sort of a couple of weeks ago declared the sort of global emergency around COVID to be moving towards next steps, I think we've got to make sure that we don't lose the sense of a need for urgency and learning the lessons from COVID. In terms of the conversation today, we're very, very keen to focus on the areas that the Immunisation for All Ages Coalition has focused on over the last few years. Firstly, how we prioritise immunisation through the life course as part of a focus on prevention strategy, as part of prevention strategies. Secondly, how we remove barriers to access to immunisation to ensure that no one is left behind. And then thirdly, to reduce inequalities in access. For those of you who are joining us virtually, please ensure you're muted while our speakers are presenting. During the panel discussion, please raise your hand and hopefully we can get the tech to bring you on screen or to at least ask your questions in the chat. If we have a few microphones here, so very keen to have everyone contributing around the table, but please do grab the mic when you do. And please do, if you use Twitter, post any comments on Twitter using the @ILC UK handle and our Delivering Prevention event handle. So I am going to stop rambling for a moment, stop my introduction. I think we're kicking off with David Salisbury, who is a good friend of ILC. He is on our Insight Experts Group. He is a member of our Strategic Advisory Board and also a member of our Healthy Aging Coalition Steering Board. And my colleague Aaron will talk a bit about that later. But David, we thought it'd be great to have David to do a bit of an intro at the start about where we've come from and where we're going from. And David is, of course, one of the world's experts on sort of immunisation and was a great pioneer in the UK in terms of what the UK did to make, particularly from the introduction of flu for adults to make it real. So David, do we have David?
Yes, you do. Hopefully you can, hopefully you can hear me, and you not sure whether you want to see me as well, but I guess you probably can. David, thank you for those kind words. It's indeed a pleasure for me to take part, albeit remotely. And I did give considerable thought to how to pitch this brief presentation today. And I thought that I would not go through the litany of existing vaccine programs that apply to the life course, but rather pick out what I see as some of the highlights that I believe we need to build into our thinking for the future. The first piece is really, where is the industry going? because that is telling us a great deal about where people have given much thought to where they are making investment in science such that they will get a return on those investments by developing vaccines and then marketing them. What we have is a sort of alphabet spaghetti of products that are in development or are already now being introduced. And we've got, RSV, respiratory syncytial virus vaccine, yes, targeted at infants, but much more excitingly, I think, targeted to older age groups. Cytomegalovirus, Epstein-Barr virus vaccine, multivalent pneumococcal conjugate vaccines, changes in influenza vaccine, changes in varicella vaccine. Why are these all happening? They're all happening because there is a need, there is science that is developing, and there are opportunities for implementation. So life course vaccination is clearly being seen as a growth area, a growth area by science, a growth area by the industry. And I think we have to acknowledge that that is highly relevant to the interests that we all come to on life course immunization. So the science and the technology are all moving in the right direction. But what have we got to then contextualize that? And what I believe we've got, just as we've had with so many other new vaccines over so many years, so many times before, we've got market segmentation. And we have, as ever, the three relevant markets. We've got the high-income countries, we've got the middle-income countries, and we've got the low-income countries. And what drives the segmentation are the socio-economic factors, and those are pushing the process of introduction of vaccines in the life course according to the markets. Now, that has nothing to do with need. That is all to do with return on investment. Is there a need to prevent pneumonia in low-income countries, in older individuals? Well, of course there is. But why do we not do that? And we don't do that in part because we don't have the data that shows us the burden of disease, and then the data that will show us the return on investment. That's not the same as in the high-income countries where we, by and large, do have better data. So there is a crying need, I believe, to be able to look not just in the high-income countries at our life course immunization, but across the piece. So my first issue is that we are falling into the old model of everything starts in the high-income countries and the others will take years before they will catch up, irrespective of the need. What have we got in high-income countries for life course immunization? Is it a success? I think the answer is no, it is not a success by and large. If you just take what is probably the easiest parameter of efficiency in implementing life course immunization and take influenza, it is not well implemented, even in high-income countries. Very, very few reach the WHO target, and many are miles away from that target. So even implementation for life course immunization for established vaccines in high-income countries is poor. We know that it's even worse in the middle income and even worse again or non-existent in the low-income countries. So what has changed some of that landscape? And David's already alluded to it. And what has changed some of that landscape, of course, is the experiences from 2020 onwards of implementation of COVID vaccination. And why was that so different? Because we were doing life course vaccination and particularly focusing on older age groups. So there are some hugely important lessons that we have to learn from the COVID experience. And there are some that are easy to draw out. mRNA vaccines, hugely transformative, astonishing. to be able to get from where we were to where we got to in such a short period of time. Scale up, unprecedented. So these sorts of things are very clear lessons to be learned. But I think that there are two other lessons that I believe are paramount that we learned from the COVID experience and we have to apply to all of our life course vaccination programs. And those two lessons are first, data, and second, program management. And unless we improve the ability to get data, and I don't just mean epidemiological data, I mean implementation data. Unless we can improve our ability to get data, and secondly, we have to improve our ability to manage our life course vaccination programs on which data is the pivot, we will not progress. And COVID did give us a lot of insight into data collection and management based on data. So these, I believe, are paramount. So what about the data? It has to be timely and it has to be based on the individual. There is no point having data on your seasonal influenza vaccine program 18 months after the event. Why not? Because not only did you miss program management in the year of vaccination, but you will have missed program management the year after that data became available. So data must be timely and it must be down to the individual level so that we know per person, and it must be actively managed. And that active management means that people at local or near local level have access to the data and are able to use the data to improve their performance. It doesn't matter what new vaccines we develop, unless we can improve performance, the vaccines will stay in the fridge. So we must improve our performance and management for our life course immunization. And to do that, not only must we work on an individual molecular level, but we must integrate into our other health service provisions so that when we accept that as people increase in age, they will increase in contact with health services for things like blood pressure, for weight management, for advice on healthy living, it's a routine to be having your vaccines checked, advice on vaccines, and implementation of vaccines that is timely and accessible to every single individual. So there are lessons from COVID. There are exciting new vaccines coming. They are appropriate to the life course. But I think there are two elements that we have to focus on and never forget, and they are data and management. So it's been a pleasure to give you these first few introduction comments, and I hope they're helpful in framing some of the later discussion. My thanks, David.
Great. Thanks so much, David. I think we've got a mix of high, middle and low income people from high, middle and low income countries here. So actually it'd be good to have a bit of a conversation about some of those during the discussion. I know we've also got from Age International, Ken on the line, so he might want to talk a bit about data later on. And I'm sure many of you know later on we're also launching our new Healthy Aging and Prevention Index, which is starting to provide, I hope, some really, really useful data, and we're at a starting point for it that could be really, really exciting. And then on the point on return on investment, my colleague Esther will talk about some work we're just doing around cost effectiveness and how we measure the value of vaccines. So lots on that. I'm now going to sort of turn to the members of the Immunisation for All Ages Coalition and start off with Jane, who I think hopefully is joining us again remotely. Do we have Jane?
Yeah. Yes, I'm here, David.
Hi, Jane.
Hi, good to see you.
Do kick off, Jane.
Look, thanks very much, David. And it's somewhat intimidating to be the next speaker following David Salisbury, but thank you, David, for setting the scene. I'm going to talk about life course approach to ageing and life course approach to immunisation. And for some that don't know, the International Federation on Ageing is 50 years of age this year. And we were born out of the purpose to ensure the rights of older people are both protected and respected. So it seems ironic, David, that the title of this session today is Leave No One Behind, when in fact we have left many older people behind, and we continue to do that when we talk about immunisation. And so when we talk about life course approach, you know, the term is used very liberally in global and national agendas, but the main outcome of a life course approach to health is functional ability. And if we actually pull that through to the life course approach to immunisation, that's exactly what we're trying to do. We're trying to both look at the functional ability of a person, but also the intrinsic capacity. But in functional ability, we actually talk about the person and the environment in which they are operating. And that's why David's comment about data is so critical. It needs to be at an individual level, but also population-based. And when we talk about functional ability, you know, vaccination is an investment in not only the function of a person, but also the quality of life. And that goes from neonates all the way through to, you know, later life. But as we know, in later life, there are three common periods, common trajectories: high stable capacity, a period of declining capacity, and a period of significant loss of capacity. Now, the focus of public health strategies, such as vaccination, varies across those three trajectories, but each of them are critically important to not only maintaining and improving functional ability, but perhaps also, if we think about residents that are living in long-term care settings, if every one of those persons were immunised against influenza and pneumococcal, the reduction of burden on healthcare systems would be significant. And that's what we don't seem to be connecting. You know, improved vaccination rates actually impacts and reduces the burden on our health and social care system. The pandemic brutally exposed not only the disproportionate mortality and morbidity on people, but also, you know, the disconnected way our healthcare systems are working. So David alluded to, but I want to reinforce the fact that older people die from infectious diseases, and older people live with significant functional decline from infectious diseases. And we know that when you hit the age of 75, 60% of us will have 2 or more chronic conditions. And when we hit 85, 75%. Why is that important? Because we've got this convergence of population aging globally, but an increased prevalence NCDs, heart disease, lung disease, diabetes, and each of these chronic diseases then makes us more at risk of infectious diseases. So David also mentioned WHO targets, and I have to put front and center, if we are talking about leaving no one behind, why are the WHO targets for influenza 95% for children and 75% for adults? We have to start asking the questions about equity, because, you know, there is an absence of WHO targets for routine adult immunisation across the board. And in a recent study from IFA of the National Immunisation Technical Groups, 2 out of 34 countries studied had any representation of an expert in the field of adults and adult immunisation geriatrics. Now, that's not to say there isn't, you know, some discussion, but we do not have the implementation of a life course immunisation program. The data paints a picture of numbers, but the real question is why? Why are the numbers so low? Why is adult immunisation suboptimal across the world? And in closing, I want to make 3 points. Vaccination is an investment in human capital. It's not only about the individual, the population, it's about our healthcare systems, which were brutally exposed in this pandemic. Disease control eliminates downstream burdens of disease and vaccination costs, health system strengthening and health equity. Vaccination also can reduce socioeconomic burdens of the acute stage of the disease, but the potentially catastrophic out-of-pocket expenses for caregivers and their families. And finally, over longer time horizons, vaccination is an enabler and driver of human capital accumulation, productivity, labour supply, income generation, and poverty alleviation. Our 3 pillars of the Immunisation for All Age initiative is prevention, access, and equity. Thank you very much, David. Back to you.
Great, thanks, Jane. And I think there are three key points that I know will come back up, and I maybe there'll be a chance if you're still with us, Jane. I know you've done some really important work around access in care settings as well, and I think that's an area which is often underexplored in terms of equity of access of vaccines across the world. And I did spot your poster in the background. For those of you who aren't aware, the International Federation on Aging has one of the most if not the most important sort of global aging conference, and the next one is taking place in June in Bangkok. So if you haven't registered, please do, and there will be a big strand around adult immunisation there. Let me now pass on to another of the members of IFAA, Martha, who's going to sort of talk a bit about from a US, we're going from Canada to the US. Martha.
Thank you, David. Is this working? Great. So first of all, let me say how thrilled I am to be here. It is actually always great to follow Jane because she enlightens me so much about how older adults are left out of the conversation a lot about vaccinations. I'm here to give the other perspective, which is childhood immunization. I represent an organization which is called Shot at Life. We're part of the UN Foundation. We're based in the US, and our mission is to make sure, first and foremost, that the US federal government is investing robustly in immunization programs. And we also do a little bit of investing and fundraising ourselves. And I think for me, what's been so interesting is to be part of fora like this, where I get to learn so much about older adults and sort of the other side of the spectrum of all the benefits of vaccination. So if I could have next slide, please. Thank you. So we aim to increase global vaccine equity so that all people, especially children, happens to have been our focus, but we are widening our lens, have access to life-saving vaccines. So as I said, we're a grassroots organization. We have volunteers all across the US and all 50 states. And our model is that we educate them on the investments of immunization, the impact that they've had, so that they are well armed to then reach out to their policymakers and make sure that, again, as I said, these accounts are well funded. Next slide, please. So just a little tooting our horn a little bit. So we were launched in 2012, and you can see from this chart, if you can read it, that it was about $300 million a year in the US federal funding for global immunization programs. It's now up to $500 million a year, and that represents, it's over the years, more than $5 billion. So we know our model works, and we're anxious to start to use it to talk about other diseases and just the importance and the investments that vaccines represent. So I know we're all here right now in the context of the World Health Assembly. WHO set a really ambitious agenda, Immunization 2030. Sorry, next slide, please. And this is their 10-year plan to recognize the importance of vaccination across all ages, not just for children. It has some ambitious overarching, some ambitious goals and overarching global vision. And obviously the pandemic, it was launched a little before the pandemic, has set back some of these goals. But I think it's important to understand that it really positions immunization, as Jane so well pointed out, this is an investment in the future. It's in creating a healthier, safer, and more prosperous world. So I think as we think about being here for World Health Assembly, we need to think about WHO's goals. And as Jane said, some of the limitations on what they're looking for targets across different ages. Next slide, please. So now onto the context for children, at least, and I realize this may be a little bit hard to see for those of you online, but the pandemic has set us back, particularly in low resource countries. 3.5 million more children missed out on their basic vaccines. So through the routine immunization services, that means 3.5 million children are at risk of infectious disease. And as we know, the problem when you talk about birth cohorts is we have these millions of children who missed, and then every day more children are being born and need to be protected with vaccines. Next slide, please. So this is a chart from Immunization Agenda 2030, which any of you can access online. I'd encourage you to, and it also has a executive summary if you don't want to read through the full report. But I think it does really position immunization and the goals we have in an important light. And one of those is just future deaths averted, right? And the target is 50 million future deaths will be averted by 2030. And, you know, you can see due to the pandemic, we are not on target for that goal. So I think we all need to work together, whether we are focused on immunization for children, immunization for older adults. I think one thing the pandemic, a great lesson learned from that is that when we work together, you know, we can really achieve a lot of things. And I think just the speed of a vaccine against COVID being available, and then COVAX, although it did have certainly some challenges, but it did show that we can work together globally and make much better progress. So part of why I'm excited to be here with you today and also to be in Geneva is thinking about further ways that we can all work together and get back on target. Thank you.
Great. Thank you very much. I'm going to now pass over to the next of our members of the coalition. We have Luis Miguel Lorenzo speaking on behalf of FIP, and Gonzalo here is a lead and very active member of the of IFAA. And I think one of the clear things that's changed over the last, I suppose, the last 4 or 5 years, and Gonzalo's talked a lot about this, and I'm sure it'll come up now, is how across the world we're seeing more and more delivery of vaccination through pharmacists, but also other preventative health treatments through pharmacists. And I think it's extraordinary. You know, we talked at a recent event a couple of weeks in Rome about almost a silent revolution in public health, where pharmacists are playing a much greater role in helping keeping us all healthy. So Lois, please.
Thank you, Mrs. Chairman. So I'll try to be brief. I'm here on behalf of FIP, and I have a short presentation. Just a sort of background, I'm a community pharmacist, practicing community pharmacist. I actually implemented in my practice a vaccination service, and I'll cover some of the information that we're gathering regarding the role of pharmacists vaccinating worldwide. So on the next slide, you can see actually what is FIP all about. We represent roughly 4 million pharmacists, pharmaceutical sciences, pharmacy educators. So within the organization, we have the skills and the expertise to leverage the impact of pharmacies and the training of pharmacists. And what we can see also on the next slide is the impact of pharmacy services worldwide. Right now, we have 48 countries and territories who allow pharmacy-based vaccination. And on the right-hand side, we actually have some information regarding what happened since 2020. That's roughly prior to the pandemic. There was an increase of 30% of the countries and territories who allow pharmacy-based vaccination. And that had a huge impact, not only on the vaccines prior to COVID, but specifically to COVID. And that we can see that on the next slide, that during the pandemic, for instance, you have some 4 cases, like in the US, roughly 50% of all COVID vaccines were administered by pharmacists. And you can actually see the numbers, both the values and the percentages in the UK, in France, and in Australia. And what we have seen as well is that healthcare systems realize that they're actually not using the full capacity of pharmacists. And what we have seen is that, for instance, in Italy and Poland, which were not allowed to vaccinate in pharmacies, so pharmacists were not allowed to vaccinate during COVID, they don't only were able to vaccinate for COVID, they were able to actually vaccinate against other diseases. So on the next slide, you'll see that, of course, we have a role on the impact of the numbers of people are being vaccinated. We also assume a compromise to increase the information, to increase the level of literacy regarding vaccination, and also to reduce hesitancy. We have further data that when you have more points of access to vaccinations, overall the numbers increase in all practice areas, not only in community pharmacies. So on our next slide, what we will see is that how you can have community pharmacists actually being involved in vaccination. You all have information. This is very comprehensive, but I just want to emphasize point number 3 regarding accessibility. So there's a study that roughly 30% of flu vaccines were administered out of hours. Means that the accessibility that patients have to community pharmacists makes all the difference on the level that they actually get into vaccination. And the why reasons keep on the next slide as well. There's some technical issues regarding the cold chain preservation and other technicalities. But overall, there's a lot of reasons why pharmacists and community pharmacists can be an active role to actually reduce the gap in all ages regarding vaccination. Then you can further see on the next slide. I'm sorry to cover all of this, but we have here 3 major points mentioned on the position statement of the immunization for all ages. And we'd like to actually propose, or at least share with you some thoughts that we've been actually discussing within FIP that has to do with the patient journey. And you can see that on the next slide. So I want to say before and after. Probably the before is a very traditional way of actually seeing the prescription and administration of vaccines. What I'm proposing and what we are advocating is that it's important to community pharmacists and pharmacists overall to have prescription rights or prescription possibilities so that the patient pathway can be reduced and then increase the number of patients vaccinated. And you can see on the next slide that actually, and then the next, well, we have the information here, in 2 years' time, we have a 50% increase of prescribing rights on pharmacists. And you actually see on the right-hand side also on the table to which vaccines that is possible. So it's not widespread. It depends on the country, it depends on the jurisdiction, it has to do with regulations, but there's a path and there's been a trend over the last couple of years. And if you move forward with the next slide, you can also see a case study from France that suddenly allowed not only pharmacists, but other pharmacy team members to administrate vaccines and to increase the number of professionals actually vaccinating. And then you're emphasizing again that roughly more than 50% of all COVID vaccines were administered by community pharmacists. And then it takes us to the end, actually, just to some take-home messages. This idea that accessibility and convenience and expertise is essential. So we have a lot of resources still to use in community pharmacists and community pharmacists. And of course, that we do have this perspective that having more prescribing rights or more countries with prescribing rights actually will allow to have more accessibility and possibilities of increasing the vaccination rates. And in a nutshell, that's it. Thank you so much.
Great. Thanks very much. And I definitely think we've seen huge change with the use of pharmacies. In previous years in the UK, for example, you could have booked a time slot on a Saturday 3 weeks in advance. It's now the case over winter period, at least, you can just pop into a pharmacy and ask for a vaccine. So we've delivered supply, which of course is great. And the progress over the last few years, places like, France, I've just come from an event in Romania, Australia. These were not easy journeys, and doctors were in some ways very reluctant. But it's really clear that there is a shortage of healthcare workers, and I know FIP are involved in an event at the moment, which is why Catherine couldn't join us. But actually, we need to use all the people we've got. So pharmacists have an extraordinarily important role. I'm going to now pass on to Martha. Martha. sorry, Martha, from the World Federation on Public Health Associations, and Michael Moore is the active member of Immunisation for All Ages, but Martha is here because she happens to be in Geneva, which is great.
Thank you very much, David. So the World Federation of Public Health Association is working very actively to support immunization all around the world, and very often with a special focus on low and lower middle income countries where the need is very high. What I want to discuss with you today is about increasing performance, as stated also in the first presentation, because, and please read that on top of everything that has been already said. Sometimes in the implementation, we forget to be practical. If you think the burden of the vaccination activities is not only on the healthcare providers, but on the member of the family that need to bring people to the hospitals, pharmacy, where they should be vaccinated. So usually is mothers. And mothers have to work full time, need to bring kids to be vaccinated, need to bring grandparents and parents-in-law to be vaccinated, and sometimes they need vaccination for themselves. And this, in most parts of the world, means 3 or 4 different appointments, different time of the day, of the week. Means that the person needs to take hours from her paid work, not easy. So we need to discuss with governments, with organizations, way to make the life of mother easier. And when we discuss that with our members, we realize that in some countries, there are very, very good examples. For example, in Brazil, we have what is called a cocoon vaccination. So in one place, you have a doctor, a nurse, a pharmacist that is able to vaccinate 3 generations at the same time. This, on one side, saves time, save money, and also create confidence, because you have 3 generations together that believe in vaccination, and we grow up the new generation, the kids, with an understanding that is something that is extremely important for my family and for the community. The second point about increasing performance is, of course, bringing the needle to the arm. And this is something already presented by our colleague from the International Federation of Pharmacists. In many countries, and again, especially in low and lower middle income countries, we have not enough healthcare providers that are able to vaccinate. And they may visit the community very rarely. But also in a more wealthy setting, people are not so keen to just go through the city, to go to the hospital, to lose time, to be blocked in the traffic jam. We need to give them the possibility to be vaccinated in the area, in a really close by to their house, and pharmacy is a very good example. But it's not enough, because many countries are not allowing pharmacists to vaccinate people. And also we may think to consider another health workforce that is less in the classical vision of the healthcare provider, that are the social workers. In some countries like Cuba, for example, the social workers are those that meet the people family by family and take care of everything, including the vaccination. In, let's say, developed countries, they are not part of the vaccinating workforce. We may think about that. But at least we may need to have them on board to create trust around vaccination and to share knowledge about vaccination. We have seen with the COVID, there is a lot of, let's say, there is a lack of knowledge. And this lack of knowledge is spread very easily among families, communities. We need trusted people that give the good news about vaccination. And the reality is that to create trust in vaccination, we need to have trust in the professional. And to have trust in the professional, we need professionals that have time to spend with people to answer to the question. And very often, the GP don't have time. So we need to think about other professionals that need to be part of this trust building team. And the third point about performance is about understanding the barriers. And this change from one country to the other country is not just money or infrastructure. That is something we have almost everywhere in the world, but is also cultural barrier, religious belief, different understanding of prevention. Just think about indigenous people and their relation with the prevention and the nature. Think about people of different religions that are, let's say, preconception in bracket about medical, let's say, approach to health. And this is not just one country, one approach, but now in a globalized world is specific cultural sensible approach to the different community within each country. Thank you very much.
Brilliant. Thank you very much. I think we ran an event in Romania a few weeks ago, a month or so ago, and one of the things that someone said there was, of course, in Romania, mothers play such an important role in these decisions, and I think I responded by saying, I don't think it's just Romania. I think across the whole world, actually the main decisions made around health of children are by mothers, and I think we need to recognise that really pivotal and important role if we're trying to think about this area. And you talked just to pick up on Indigenous communities. I might ask Aaron later on to talk about a piece of work we've recently done around access to pneumococcal vaccines amongst some of the different communities around the world and some of the lessons from that. But before that, I'm going to ask Esther to come in finally. Esther is from ILC UK and is leading a project we're doing, which is looking at some of the things that David hinted on at the beginning around how we do measure cost effectiveness. So how we think about cost effectiveness in the context of vaccines. So Esther.
Thank you. So thank you all so much for being here, and thanks to our panel of speakers for bringing their expertise to this event. As David said, I'm leading a project at the moment about life course immunisation. And as we've heard so far, advocating for and then implementing preventative interventions such as life course immunisation is hard work. It's a lot easier in some cases to respond to current emergencies and short-term issues than focus on the long-term. And it's also easier to comprehend health system spending on immunisation than it is to comprehend the wealth of benefits that immunisation brings. So my next slide will, as it's there, this is the way. So from this slide, you can see the way we've chosen to advocate for life course immunisation is from a cost effectiveness paradigm or standpoint. So there's a variety of methods to calculate what is gained when we prevent disease, but there are some challenges to each. And we also know that the value of immunisation is too often underestimated. So the slide you can see here is a figure published in a report by the Supporting Active Ageing through Immunisation Partnership. ILC UK conducted the research on adult immunisation, which contributed to this report. And what we can see here is across the life course, each euro spent on vaccination will generate a return of at least €4. But this return can be significantly higher depending on the context and region in question. If we could go one slide back. Thank you. So we can see from this slide the various costs of an outbreak of vaccine preventable disease. As we can see, the straightforward medical costs which result from an outbreak of, in this case, measles, are only a very small fraction of the total. So we can see that a larger proportion would be the productivity costs, meaning days of paid work missed, and the vast majority of that spending was on the public health response. This does not account for all of the non-economic costs that we will all be familiar with post-COVID. So the informal care for family and neighbours that could not be delivered as usual, the lack of contact between families and communities during quarantine, and the volunteering, hobbies and sports that were disrupted. All of this has a significant knock-on effect on our personal health and on our broader economy over time. So in an aging world, immunisation is more valuable than ever. We want people to live more of the extra years they have in good health for their own benefit and for that of the wider economy. So it's common sense that keeping people well is better than reacting to ill health once it's developed. Long-term investment in preventative health is a difficult political and practical task. Next slide, please, and then the following one. Thank you. So as you can see, ILC UK has a long-standing expertise to draw on in terms of adult immunisation, and this slide lists some of our previous reports. But I'll conclude by saying that the COVID-19 pandemic has given us an opportunity to reassess how we use preventative measures. Prevention, as my colleague Aaron will outline in her launch later on, is not just a nice to have, it's an investment in population well-being. Adult immunisation can also deliver significant returns in economic terms. It can also support more of us to live healthier for longer and spend more time doing the things we choose. Thank you.
Great, thanks. I know Martha earlier on talked about this quite significant investment from the US, and I think clearly what we would hope is that some of the work we're pulling together some of this data actually is useful for you, Martha, in terms of actually making the case to policymakers and indeed the rest of us, because as we know, you know, that 1 in 4 figure is quite old now. The 4-to-1 return actually. You know, we know we massively underestimate the value of vaccines because we don't take into account particularly non-market value of vaccines when we're thinking of when decision makers are deciding whether or not to introduce them. And of course, in some cases, it's almost impossible now to come up with cost effectiveness, because if you've in effect eradicated the disease, you can't prove cost effectiveness anymore because we don't, you know, but clearly really interesting and important that we are getting this message out to policymakers. I'm going to open up to sort of a broader conversation, but perhaps kicking off with, do we have Susan Schwartz from the Global Coalition on Aging on the line?
Yep, I'm here, David.
Hi,
Can you
Susan.
hear me?
Can you want to sort of respond and kick off the conversation?
Yeah, thanks so much. And, you know, thanks for this really great discussion and letting me get this next part started. I'm here from the Global Coalition on Aging, and like Jane, David, and many of you, we're thinking about, you know, IA 2030 through the lens of aging in particular. I think the insights are broadly applicable, and vaccines for older adults often have largely been left behind, as Jane made so clear. One of the most important points we try to make clear is that widespread uptake of adult vaccines is a shared interest across society. So not just ministries of health, but, you know, including government and ministries of finance, employers, caregivers, individuals and their families. So I think we're particularly excited about the research that Esther's leading. I think on a positive note, I think that IA 2030 with the decade of healthy aging from the UN offer a really important framework for us to better prioritize life course immunization, and in particular vaccines for adults, if we're able to set it as a priority. So listening to this discussion, there were 3 opportunities that we felt to prioritize that really come top of mind for us and for this conversation, especially related to the strategic priority 4 on life course and integration. The first is, you know, meeting people where they are. This includes expanding access points, you know, expanding the cadre of people who are able to administer vaccines, starting with community pharmacists, as Luis discussed, and vaccinating opportunistically, as Marta touched on. But this also means meeting people where they are in terms of understanding and concerns, which brings me to the second, which is communicating differently and more. It could be expanding the number of trusted advisors across the health ecosystem who can and will speak to the importance of vaccines, talking differently and hearing concerns people may have about vaccine safety, and helping people see themselves as someone for whom immunization is important. And, you know, on that last point, we recently had a project that centered caregivers. We talked about that, you know, mothers and adult daughters to, and many others, to first of all, help them even self-identify as a caregiver, because we realize that lots of people don't even realize they are. And second, to help them understand that their health status matters a great deal to a lot of people, and that protecting their own health, something that they probably put last, is actually quite critical to their ability to protect those in their care, be it young children or an aging parent. And the third opportunity we're seeing here, as Professor Salisbury raised at the outset, is better and more widespread use of data for decision support. And that means, you know, better disease surveillance as a starting point, but also better tracking of who and where people are getting vaccinated, including by age. and also making data available and usable for individuals and their care teams so they can make informed decisions about what vaccines will be beneficial to them, whether they're up to date on their eligible vaccines, and where they can get them. So collectively, we really see tons of opportunities to advance these ideas, especially for older adults through that, Immunization Agenda 2030 framework and the Decade of Healthy Aging. And, as we look towards mid-decade, we really believe now is a time to build on what we know has worked well, for example, in childhood immunization in the past and the whole of society efforts we saw with COVID-19. But at the same time, make a concerted effort to learn from what perhaps has worked less well. So I'm just going to put these ideas out there and kind of kick off or get this conversation started from the colleagues in the room. Thanks.
Great, thanks, Susan. I'm very, very grateful for you to join, particularly not least, but well, it's great to have you on board, but actually also, of course, because I'm very conscious of what time it is in the US. It's still quite early for you, I think.
Got my coffee.
Yeah, I'm gonna open up to any conversations, anyone, and this is an opportunity not necessarily for Q&A, but for sort of any reflections or thoughts on the contributions so far. I wonder if I could pass to you, Sylvie. Yeah.
Thank you very much.
Please introduce yourself. Sylvie.
Okay. So I'm Sylvie Briand. I am the director of the Epidemic and Pandemic Preparedness and Prevention Department at the World Health Organization. So my department is in charge of COVID-19, of course, but also monkeypox, influenza, and other pathogens that are emerging and may pose a pandemic potential to humanity. And so, of course, we value very much vaccines because vaccines are tools that have been produced in the past to deal with epidemics and pandemics and have significantly changed the vulnerability of humanity against those pathogens. And so I think what really resonates to me is that indeed the world has more focused on vaccinating children in the past, but more and more we see that elderly, for instance, are more likely to get severe disease and death, not only from influenza, but COVID also has been an example. And I think the problem is that we still lack vaccines for people with weak immunity. And I think because, I mean, children usually they have a good immune system, but elderly or people with underlying conditions, they don't. And this is why not only we don't have a good vaccine, but their effectiveness is also lower. So I think we should push research towards really producing products that could be more effective for this type of people, and also or maybe we should change a bit the paradigm and see if maybe associating it with, I don't know, vitamin D or something that will enhance the effectiveness of vaccine, and this product could be delivered at the same time, and maybe it would help to also have better effectiveness for those new vaccine. The other thing I think is that we need to have a better narrative for vaccine in elderly population in particular, because and I think I think it's Jane who mentioned the burden on health system, which is true, but I think we should also highlight the burden on the rest of the family when an elderly person is in bed and has a significant functional decline, and then the entire family has to take care of this person. And so it's a burden, I mean, an indirect effect of a lack of prevention of those diseases for the family. So I think we should also put this into the narrative and try to find more arguments to convince that it's a good investment to invest in vaccination for elderly people everywhere in the world. And also, I think it's because I was talking about people with a low immunity or weak immune system, but in fact, even in developing countries, I mean, young children, malnourished young children also have a weak immune system. HIV people have weak immune system. So it's not only the elderly, but in general, all people with weak immune system needs to have special products, in my opinion. And finally, I just would like to highlight the issue of the COVID-19 pandemic and the vaccine hesitancy that we have seen. And for me, it's really sad to see that the number of people against vaccination has grown, not only against the vaccine, COVID-19 vaccine, but also all other vaccines. And really, we are back to a situation that we have good tools, but the population doesn't want to use the tool. And I think this is really, really sad. Because the science has made a lot of progress, but then if the population doesn't want to use the tool, what does it mean? So, and that's why I think government should also invest much more in what we call infodemic management, is the management of this new information ecosystem, where people are bombarded by information, accurate or inaccurate. So at the end of the day, they don't know really what to do. And so we have now, we have developed a new scientific discipline called infodemiology, where we try to understand better what is going on with this new information ecosystem, and also how people their information diet, that we call, how they are consuming this information and how they make a decision based on this information. And what is really worrying is that now we have network analysis, and you see that before this pandemic, a lot of people were undecided. And after the pandemic, they have moved really towards the anti-vax. And so I think this is really sad. We need really to revisit really our concept on how we talk about vaccine. And I fully agree with you, Marta, that we need to take much more in consideration the cultural and religious belief and all the context in which people are, and stop considering only vaccine as a product where we only focus information on the safety and the efficacy, but really understand that prevention is a way of life, is a way of seeing our own health, and integrate vaccine into a much broader perspective so that we can better understand also the barriers and the resistance to accepting vaccine. And just to finish, because I don't want to talk too much, but just to say that, for example, in China, when they had the last wave of Omicron, they did a mass vaccination campaign in the elderly population. But one of the major resistance is that elderly thought that Chinese traditional medicine was much more effective than the vaccine. So I think we need also to take this into account and to promote vaccine throughout the life course. So thanks a lot.
Great, thanks so much. And I can see we've got both Ken and Jane who want to come in, but so whilst we're just sorting out the tech, a couple of observations. I think I saw in terms of information, I read recently that we pick up our telephones 47 times a day because of a notification that's sent to us. You know, that data coming at us all the time is in some ways quite oppressive, although we had a fantastic Romanian doctor who joined us in Bucharest a few weeks ago, who set up his own Facebook page and has something like 1 million people every time he posts sort of thing. So there is ways of using the tech. Really pleased to hear your comments around adults. And we know that if we keep people healthier, people work longer, they volunteer more, they care more, and they spend more. So extraordinarily important. Yes, while David highlighted that in most wealthier countries, we don't do adult immunization well. We've got a bigger challenge, I suspect, in some of the lower and middle income countries. So I might use that as a hook into Ken. He might want to talk a bit about that sort of diversity, but also maybe a bit about data, Ken.
Well, actually, I think the data point has been covered, so I'm probably won't do that. It's been really rich discussion so far. So I just want to thank everyone for the contributions. And I guess maybe going back to kind of where David started us off with, which was, you know, those two great initial points to consider in terms of how we progress with this. I'd just like to add a third, which Sylvie was alluding to, which is the adoption of vaccine. So it's not just about data, it's not just about program management, but actually how do we get people to take the vaccines themselves? And here I think that there's two key points to make. Again, Sylvie alluded to one of them, which is the vaccine hesitancy and the distrust for vaccines, and I'll come back to that point. But there's another point which hasn't been mentioned yet, which is ageism. We have both an internalized ageist attitudes, and I say we because we all have it across the globe, thanks to the fantastic work the WHO has done. You know, this has been evidenced. But of course, there's the systemic ageism that exists with both within health systems as well as the kind of the community structures. And we can't avoid acknowledging the fact that, yes, while of course there is a lot of respect for older people, there is still in many cultures, in many places of the world, this lingering thought that, right, well, if we really have to spend the time and the energy and the money, is it better going to a child? Is it better going to an older person? And unless we grapple with that head on, this whole conversation we're having about adult immunization really won't come to anything, frankly. I think one of the ways that we can get that cut through is to focus on some of the themes that are coming through the World Health Assembly at the moment, and the discussions that are happening more broadly over this year, which is around investing in primary healthcare, investing in community-based approaches. This has come up a few times in the discussion already, but it's really about that's how one localizes the delivery of vaccination. It's by making sure that you do have those strong health systems in place at a primary, at close to where people live as possible. But crucially, it's about involving people themselves and giving them agency. And I love that idea that was mentioned by Marta about having the multi-generational vaccine delivery. I think that also could be a really useful way of helping to get past the vaccine hesitancy. And, you know, I think one of the things, again, we've seen time and again, but it's not just a matter of having a campaign for information on vaccines. It's how does that information get delivered in a way which is appropriate for the people receiving it. So that could be one way of approaching this in a novel way. Thanks.
Great, thanks, Ken. And I can see, Jane, you've got your hand up, and I know ageism is a huge theme for you, but let me pass to you, Jane.
Look, thanks very much, Dave. And I concur with Ken about ageism. We certainly saw that alive and unhappily well during the pandemic. But I want to follow up on a couple of comments. The word narrative's been used. Work that we've done across many countries shows that the public health messages are not targeted and the narrative is a standard. And so that comes to this prevention part, the education. You know, I also want to be the devil's advocate and suggest that we use this word vaccine hesitancy very liberally when it comes to all of the populations and older people. You know, it may be that there are modifiable barriers, and we know that that's the case. So the lack of transport, the lack of access, the cost of vaccines, these are all barriers. And somehow, because an older person is not vaccinated, they're viewed as hesitant. That's not the case. And that means that we've actually got to understand the modifiable barriers at a local level. And that will change within country, within county. So we really need to understand that, because policy happens at a national, provincial, local level. And systems to enable an older person to access preventive medicine, such as vaccines, happens very locally. And so it really is taking the IA 2030 and the decade agenda and pulling it through to a very local level. My last point is around investment. It's not only investment in the vaccines, it's investment in the pathway to be vaccinated. So that's why education, awareness, you know, our work clearly indicates that, and, you know, healthy older people are older people. Frail older people are older people. We do not have a homogeneous older population, but we seem to just put them all under the same umbrella. And so we really have to understand the target population, just as we understand mothers and babies and grandparents. It's about who are we talking to and what are they receiving and what do they need to make an informed decision? Because we're missing this, aren't we? everybody's got the right to make an informed decision. And so what information can they hear to make that decision? Thanks, David.
No, thanks, Jane. I think one of the other things, of course, clearly that came from COVID, and I know you've done really important work on the composition of night eggs, is actually we don't engage behavioural scientists well enough in this space. We don't engage people who understand how we might react to certain messaging, and clearly, again, role of pharmacy extraordinarily important. Do you want to come in, Dominika?
Thank you. My name is Dominika Pinterova. I'm a representative from International Pharmaceutical Students Federation. Vaccine hesitancy is one of our key policy topics, especially since the COVID pandemic, but even before. We represent over 130 countries who are able to submit their stance on this topic. From what we found out, that we believe that this problem varies between and also within countries, context, and time. For some certain aspects of it is that, as it was also mentioned, as individuals lack confidence in the ability of the healthcare system to provide vaccines safely. Another problem might be that the mode of administration of the vaccines can cause certain problems. There are people who opt out just because they are fear of injections. And another problem that we see in certain countries, especially, is that there are healthcare professionals who are not willing to get vaccinated, and that influences the general public as well. We believe that the most effective interventions are multi-component, and interventions should be dialogue-based and directly targeted to a specific under-vaccinated population group. And to close it, I would like to highlight once again that we believe and we advocate for the pharmacy profession to be a more crucial stakeholder in immunization processes. And therefore, since pharmacists are one of the most accessible healthcare professions, also a key partner in ending vaccine hesitancy. Thank you very much.
Great. Thank you very much. And I should say one of the reasons I'm optimistic about the future in terms of, and not least because we have some amazing young people like yourselves who are actually out there. And I'm having a young daughter who is so much smarter than I was at her age and has so much better access to information. I think we've got to be optimistic about actually the future generations and how they may respond to the new technology we have. Gonzalo.
Thank you very much. Gonzalo Sousa Pinto. I'm with International Pharmaceutical Federation as well. Just to comment on Dr. Briand's 2 points before, and I couldn't agree more that I think that we need to strive to have more effective vaccines. But I think that the point is also with the vaccines that we currently have, are we doing everything we can to actually get as many people vaccinated as possible? Because we have vaccines that are very good, and we've seen that the impact that has in terms of disease prevention, in terms of bringing the pandemic under control, in terms of keeping older adults and people with comorbidities protected from more severe forms of disease. But are we actually doing everything we can? Because vaccination rates globally remain suboptimal from so many diseases. So while agreeing that we need to strive for more effective vaccines, I think that we also need to think if we are actually, it's almost like an ethical imperative with the vaccines that we currently have. Are we doing everything we can to protect the most vulnerable people and in our societies, in our communities? And with regards to your second point about the infodemic management, again, we couldn't agree more. It's a critical issue at global level, the lack of confidence in vaccines. And as Jane was highlighting, a lot of the messaging is not targeted messages. There are standard messages that might not be applicable to individual concerns or groups within the population. But again, I think that we would like to highlight that a lot of the efforts of addressing concerns and overcoming those concerns and that hesitancy is through individual interactions, is by listening to specific concerns that an individual might have and that may be completely different from another individual that we might just label as being from the same group, let's say. So, and those individual interactions and those meaningful conversations are the ones that are taking place daily in many millions of pharmacies around the world. And when you really have the opportunity to have those conversations, to address and understand those individual concerns, and provide evidence-based advice in a lay language, in a language that can be adapted to the individuals that present those concerns. So just to like to mention those 2 points. Thank you very much.
Great, thanks. Do you want to come back on those or?
Yeah, no, just I fully agree, and but that's why I was really trying to lay out what are the challenges of the future, so that we can also focus on them. And I'm very happy that you mentioned the listening, because I do think that because I work also mostly for crisis situations, so it's slightly different, but we tend during crisis to have really this top-down approach with messaging rather than listening. So I think if we can advocate for future pandemics, but also for future routine vaccinations, to put listening before the messaging, I think it would be really good, so that I'm sure we will progress on this.
Right. Thank you. And a couple, do you want to come in and then, yeah, and then can we pass the mic along? Yeah. Luna.
Hello, my name is Luna Al-Bizri. I'm from Lebanon. I would like to start talking that really I am from Lebanon before saying that I'm a community pharmacist and I am an FIP EXCO member. Why? Because Lebanon was one of a high middle income country, and now post the crisis, it is unfortunately definitely a low income country. So what's going on and why vaccines? Jane, I think Jane has said a lot of things that are important, because it's not important only to educate, because let's see, the population in Lebanon is divided into two groups, if you want to say, the Lebanese and the immigrants, migrants and refugees. If you want to talk about the Lebanese, they are well educated and they believe in vaccination. So the problem of educating is not there. And before this crisis, let's say, even we are talking about healthy aging, I want to give you a note about the adolescents and how well we were doing for the HPV vaccination, because people were able to pay. So one of the biggest barriers is who is paying for this vaccine and which vaccine are in the calendar, the national calendar of this country. So does Lebanon find that old age are one of their priorities? No, they aren't. Why? Because they are looking at the index, at the numbers and the figures. Maybe the priority in Lebanon is to decrease the mortality or morbidity of the children and the mother. So now, it is not on the top of their priorities and on the agenda. And this is a big problem. And even now, if I am a community pharmacy and I'm doing my job very well and I'm educating the old age, and unfortunately, there's a lot of vaccination that are intended for the 65 years old. There are no more in Lebanon because they are so expensive if we want to pay it out of the pocket of the persons. And the government is not funding these. And if we go there and see, okay, we don't want the government, we don't want the patients to pay. Let's go and see who can fund this. Maybe another NGO. And this NGO, each NGO has its own agenda, because maybe they are looking for, their target is for children, maybe for the adolescent. And unfortunately, in Lebanon, no one is putting these old patients as number one in the vaccine calendar. So this is what I wanted to say. It's one of the biggest barriers. It's not only education. This is the Lebanese population. And if you go to the migrants and the refugees, it's another problem, because they won't go out, they won't go to the clinicians. They don't, we do have a good system of primary healthcare centers for these refugees, and they have the essential vaccinations for the only children. They don't look at not because they want to neglect them, not because they are looking at them, they are not important, but because there is the problem of funding, there's the problem of how they can get out these old patients to get vaccinated in this primary healthcare center that sometimes they are a little bit far from where these people are. So these barriers we have to consider these barriers whenever we are looking in a country. It's not always the same everywhere, anywhere. And finally, this is very important. I cannot agree more about post-COVID. What is good about Lebanon, that we have the fastest response during the crisis, but when back to normal, we forget about anything, and we don't have this sustainability. So what is important also in vaccination is not only doing a huge and great job during crisis, we have to build on to have really a sustainable long-term calendar for vaccination for all ages. Thank you very much.
Great, thank you very much, Anna. We've got a couple of people in the room and Elaine are online who want to say add some words. I'm going to pass to Hans, and then if we could have the mic over here, and then I'll go online, and then we may need to sort of conclude. So Hans.
Yeah, my name is Hans Groth. I'm the chairman of the World Demographic and Aging Forum based in Switzerland. And if I understood correctly, we have gathered today to advance the opportunities for longer healthy lifespans through vaccination. That's why we gather here. And if I observe where we stand as today, following the recent experience with COVID, we have reached an area with skepticism, an area of lack of confidence of what has been achieved, although the success has been huge. And I may call it, we have a general fatigue despite tremendous success. Now, if I'm well informed, the total burden of COVID was 4 million deaths, roundabout. And about 90 years ago, we had, again, another big pandemic, the big flu. This was 40 or 50 million. Can you imagine at the time where we had 2 billion people on our planet, and today we have more than 8 billion. So the success has been huge. But on the other hand, we have an ongoing attitude in the population, and I think it's all across the world. We have a skepticism, and we have some unspecified behaviors, values, and beliefs if vaccinations are good or bad. We cannot explain it with natural sciences. And I would like to make you aware this phenomenon is not new. Maybe it's more exaggerated because we have more intense global communication, but it's not new. And I can give you examples from history. The skepticism against vaccination is as old as vaccines. It's 200 years old. And I give you very interesting examples on this. And therefore, it's my big plea today. It's very, very important to have good research, more development on better vaccines. There's no doubt about this. Or even better data, how effective, what is the impact on public health, etc., etc. But even more, and I think we have a little bit ignored to do more research on this, which it has been mentioned by some of you already, it's behavioral science. Why behave people in such a way that they are skeptic or even dogmatic about something where we have real evidence? They simply ignore. In addition, they have the power to communicate successfully and penetrate their beliefs. You know, their successors are in. And the next final thing is those who are affected less communicate the most, and not those who are benefiting most. They are the most silent ones. You know, if you look at our opponents or barriers or obstructors are those who are the youngers or the mid-agers. And in terms of elderly people, the resistance among elderly or skepticism amongst vaccination and elderly generation is, to my understanding, to my experience, comparatively low. So the resistance and the noise comes from those who will benefit to a lesser extent. And once again, I really would like that we join forces to do more research and good data to understand the barriers. Thank you.
Thank you very much. And we've got a few minutes left. I'm going to pass over here to our colleague over here.
Thank you. I'm Prosper FIP, but I wanted to mention that I'm coming from Cameroon, a low-income country. What I wanted to highlight is the issue of the access. Where are the vaccines? The vaccines are not in low-income countries. We don't manufacture vaccines. We don't have vaccines. So it is clear. And when the vaccines are there, how vaccines reach the poor people in the remote areas? No roads, no electricity. How to store vaccines? Do we have cold chain? These are challenges that we have to think about when we are talking about vaccination in low-income countries.
Great, thank you very much, and really great to have that contribution, because I'm very conscious we all talk from a very different perspective, where vaccines are much more available and where actually the logistics of getting vaccines around are actually, frankly, a little bit easier. So extraordinarily important we have that global recognition, both from yourself and indeed from Martha earlier on. Final contribution on line from Elena. I see. Can you hear us, Elena?
Thank you for the invitation. I represent a patient's voice today. I work for COMO. It's well known for many of you. COMO stands for Confederation of Meningitis Organizations. I have taken notes of these wise advices from all the participants, and I just wanted to share with you all the work that we are doing from the patient's voice to spread the voice of prevention, of the benefits of prevention in a life course span life. Meningitis can affect anyone at any age. And in Europe, Dr. Taha and Professor Veil-Olivier are leading the work to share the data of all these older adults. They don't like the word elderly, so the older adults that are being affected by meningitis, overall the MenW serotype of this bacteria, meningococcal bacteria, and it's a work that will prove that prevention for our older adults are needed to prevent them from meningitis. We share the information of preventing each of them, and also to implement this protection into routine vaccination calendar. Thank you so much for this outstanding and very interesting roundtable.
Great, thank you very much. And Como, we're up until very recently a really active member of the group, so extraordinarily important in this debate. I'm very conscious of time, not least because we need to move the tables around. We have lunch available for those of you in the room, sadly not for those of you online, so I'm sorry about that. We should have sent you vouchers or something, shouldn't we? Sorry, you could have had a delivery order or something. I should have just done very briefly my slight declaration of interest here. Very grateful to Pfizer for their support for the Immunization for All Ages Coalition, but also very grateful for Amgen, MSD, GSK, Sanofi, and Pfizer for their support for the work that we've been doing and others around the table around prevention. And we will later on this afternoon be launching our new global health index around and we have both Les and Aaron here who've been pivotal in creating this, and we'll be joined by the Canadian and the Singaporean health minister. So please do stay if you can. Final comment for me: immunization for all ages. I think all of us in the room are really supportive of what WHO is doing and trying to do in this space. Clearly in one, the WHO as part of the agenda has said, look, we expect every country to have national national plans. Now, I think we've all got jobs to make sure that every country does have a national plan on immunisation, and that actually that is comprehensive and covers all of the things we talked about today, including adults. So at that point, I'm going to stop and thank you all for joining us and online, and we will have lunch now. But thank you very much, everyone. Thank you.